Good evening. Good evening, everyone. Today, the Education Committee of the Physiological Society of India is going to organize its online lecture series. The lecture number 31 of this session is on the topic of the physiology of circulation. Will be delivered by Dr. Kalyani Mallipeddi, who is a distinguished professor of Department of Physiology, Government Medical College, Khemmam, Telangana. Prior to start the lecture, I would like to introduce her in front of you. Dr. Kalyani Mallipeddi is an accomplished academician and dedicated medical educator, currently serving as professor and head of the Department of Physiology at the Government Medical College, Khemmam, Telangana. She completed her MBBS in the year 1999 and MD in Physiology in 2004 from the prestigious Guntur Medical College, Guntur, laying a strong foundation for her career in medical education and research. Dr. Mallipeddi contributed significantly to academics and institutional development during her long tenure at NRI Medical College, where she served until December 2022 before joining the Telangana Medical Services. She has continually advanced her expertise completing the advanced course in medical education with a deep passion for teaching and mentoring to enrich her pedagogical approach. Her commitment to fostering clinical relevance, critical thinking, and innovation in physiology education has made her a respected leader among colleagues and an inspiring mentor to the students. As head of the department, Dr. Mallipeddi continues to set the academic environment with vision and dedication, strengthening both the educational and professional standards of physiology at Government Medical College, Khemmam. With this brief introduction, I invite Dr. Kalyani Mallipeddi to deliver her today's lecture. Over to you, ma'am. Please.
Yes, sir. Thank you. Am I audible?
Yes, sir. Yes, ma'am. You are
Yeah.
audible.
Very good evening. At the outset, I would like to thank Physiological Society of India for giving me this opportunity to deliver my lecture, and I'm very thankful to Dr. Naik sir, who introduced me to this PSI online classes. Thank you. So I want to share my screen. My screen is also visible?
Yes, it is coming. Yes, now it is visible to all.
Is it okay?
Yes, ma'am.
Right. So, very good evening. Today, my topic coronary circulation. So, this topic is having much of clinical significance, and in the scenario, what we are seeing in our day-to-day life, the COVID deaths, post-COVID especially, sudden deaths due to myocardial infarction have become very much common even at young age, right? So, what is the physiology behind this, and what is the cause? Leave alone the COVID and all. When we are talking about the myocardial infarction, it's very important for us and to know about coronary circulation. What is coronary circulation? Basically, coronary circulation is the circulation of blood supplied to the heart itself, right? So the blood is pumped by the heart, what we call cardiac output. And approximately 4% of the cardiac output is the blood flow to the heart. Approximately, we can say around 225 or 250 ml per minute at resting stage. And being in the dynamic status or requirement as it changes during exertion, during increased physical activity and other conditions, the coronary blood flow can be increased to as much as 5 to 6 times, or it may go almost up to 3 to 4 times, or even more than that as required, right? So in this scenario, there are dynamic changes that are occurring in the body, and the blood flow is adjusted to the various organs and accordingly to the heart also. So when we speak of in this 1 hour section, we'll be initially talking a little about the anatomy of the coronary circulation. And this anatomy will correlate to the physiological aspects. And when we talk about the physiological aspects, it goes without saying the very important thing is phasic changes in the coronary blood flow. So the peculiarities we'll be knowing. Of that, we'll be stressing more about the phasic changes that occur in the coronary blood flow. And this, after this, will correlate what factors affect the coronary blood flow and how the readjustments or regulation of that coronary blood flow is occurring. And finally, we'll be implying this to the clinical scenario. In that, we have mainly ischemic heart disease as well as cardiac failure. So we'll see all these things one by one. So at the outset, we'll start with the coronary blood flow. The coronary blood flow is very important anatomically because of the blood supply to the various organs. We say the aorta, ascending and descending aorta, they give branches, and these branches in turn supply various organs, right? However, when we talk about coronary circulation, the significant thing what we need to stress, this is a direct branch. The coronary arteries are direct branches of aorta, ascending aorta. So they arise at the base of the ascending aorta from the sinus, valsalva sinus. So this is very important. So only two vessels in our body, mainly the coronary and the renal artery, these two are direct branches of the aorta. So the coronary from the ascending and the renal, it is from the descending aorta. These are the direct branches from the aorta. All others, they are coming from the branch after branching, the arteries branching into the further once they branch, right? So here, these two arteries, starting with the right coronary artery. So if you are able to see here, so if you are able to see, this is the right coronary artery, which is emerging at the base of the aorta from the right sinus, right? So this is emerging, and this is, as it comes down, this is running in the atrioventricular sulcus. So these sulci are nothing but, that are the depressions that are running on the surface of the heart, right? So in that sulci, it will be running, and it gives the rami. So these rami are the branches which supply the immediate muscle or the heart that is near to it, right? So one such rami, it supplies the SA node, right? So SA node is the pacemaker, right? So this rami will be supplying the SA node. Now this runs in the sulci, and as it goes back, it gives a marginal branch. So you can see the marginal branch, right? So this is the apex of the heart. So this is the marginal branch, that is. So this is the anterior aspect of the heart. And as it runs, if you see here on the posterior aspect, so this is the coronary artery, right coronary artery that is coming. So usually this coronary artery ends here. So this is the point where the interatrial septum, intraventricular septum, atrioventricular septum, all these meet. So this is the point, right? So at this point, most of the time either it ends or it runs down, giving interventricular artery, right? So the descending interventricular artery or posterior descending branch of the right coronary artery, right? So basically, if it ends here, that will be supplying only up to this part, and if it goes down, this becomes the major vessel that supplies the major parts or components of the heart. So in this point, I want to again tell, if you observe, this is the right coronary artery, This is the left coronary artery, right? So this is the left coronary artery, which is giving the circumflex branch, and also it is giving the anterior interventricular or anterior descending branch, right? So if you observe, these are ending. So the branches of the right coronary artery, you don't see the anastomosis. So it is important anatomically and physiologically to mention this point. These coronary vessels are end arteries, meaning that they are not having uh, means the final branches, arterioles and all, they are not having anastomosis with each other. So they are end arteries. So the major vessels are end arteries, stress upon, whereas the vessels, smaller branches, they have minute anastomosis, which usually are negligible, but their clinical significance is that once the blood flow is occluded gradually among these vessels, the major vessels, these anastomosis, they develop and become collaterals. Thereby, they compensate the decrease in the blood flow to that area. Am I clear? So the important point, anatomically, though it is, we say it's an end artery, and they don't have an overlap of the territories of their supply. So once a vessel is occluded either by thrombus or emboli, the blood supply around that innervated, supplied area will be affected. So if it is a chronic, like a plague is formed and it gradually increases in size, obstructing the blood flow, these collaterals gradually start developing. But however, it's not to completely compensate, but definitely it will be helping to nourish the area that is infected in the sense that is having ischemia, right? So when it is a chronic scenario, gradually the plague increasing in size and obstructing that vessel, diminishing the blood flow, these collaterals of smaller branches, they develop and may give blood supply, right? But however, if it is a sudden thrombus or emboli, dislodge thrombus, if it dislodges and occludes one major vessel, the blood flow is compromised very much, because there are end arteries basically, and very small little collaterals that are there at the end, anastomosis at the end, they don't usually help in that acute situation scenario, right? So the area that is supplied by each vessel is clinically important, especially for the cardiologists and cardiothoracic surgeons, right? So that will again uh, take that point again when we talk about the applied aspects. So at this juncture, the right coronary artery, we said, if it gives a posterior interventricular descending vessel artery, that becomes the dominant vessel. Means when we talk about the area that is supplied by each of these vessels, right coronary artery and left coronary artery, so the right coronary artery will be supplying blood to the right atrium, right ventricle, and if as it goes back, it supplies the posterior aspect of the left ventricle. And if it is going as a descending branch, it will be also giving the posterior part of the interventricular septum. And now it becomes the dominant vessel. So one more good or peculiar aspect of this coronary circulation is these are, one vessel becomes dominant, or sometimes both are giving equal supply to the wall of the heart. In the sense, the right coronary artery, if it gives the descending branch, it becomes the dominant. So in almost 50% of the individuals, the right predominance is the scenario, and in 20% of the persons, the left coronary artery, if you see on this anterior aspect, it is going back, and the circumflex that is there, right? So the circumflex, it goes and it supplies this. So in the diagram what is given here, we are showing the right predominance. So in the left predominant cases, this will be going and it will be going down in this interventricular septum, and that becomes the left predominance. In that is in the 20% of the persons. In the 30% of the persons, there is codominance. So equal distribution almost. This will be there and this. So both will be sharing and that becomes codominant supply, right? So that is about the anatomical aspect and its clinical significance. So when we do the angiogram and when we talk about the area that is infected, we are also giving importance to this anatomical point. And when we talk about the sudden or chronic decrease in the blood flow, ischemia, we are giving importance again to the collaterals that develop with chronic situation, right? So one more important thing, these vessels, they are running on the superficial aspect of the heart. And when we talk about the layers of the wall of the heart, we say there is an epicardium, myocardium, endocardium, right? So the epicardium, when we talk, these vessels are running, and from the epicardial to the endocardial area. So if you see the epicardial vessels, they become the muscular arteries, or penetrate. They penetrate in a perpendicular fashion to reach the endocardial area, right? So this is the endocardial area. So these, they become the subendocardial plexus once they reach the subendocardial area, right? So this again becomes one of the feature we should consider when we are talking about the physiological aspects of coronary circulation. So I again repeat, these epicardial coronary vessels, they become as they become the muscular arteries or branches, they penetrate in a perpendicular direction and they reach the endocardial surface, right? And they form the subendocardial arterial plexus, right? So they are supplying the myocardium and endocardium. In this, at this point, I would like to also add the subendocardial arterial plexus is there, and endocardium, almost one tenth portion of the endocardium is in direct. The endocardium is in direct contact with the blood that is there in the chambers of the heart. So from this blood, one-tenth portion of the subendocardium will be able to extract the oxygen or nourishment, whatever, right? So this again I will recall when I talk about the phasic blood flow. So this is the point to be remembered at this juncture, right? So coming to the venous drainage. So the veins usually, they are also running in the sulci, and the major cardiac veins, that is the anterior cardiac vein, the great cardiac vein, there are two systems here, right? So these are the major vessels that run on the superficial aspect. So these superficial vessels, they empty their blood into the coronary sinus. So this coronary sinus in turn empties into the right atrium, right? So they empty into the right atrium. And there are some deep system where the Thebetian vessels, arteriosinusoidal vessels, they also empty, but not into the coronary sinus directly. They empty into the chambers of the heart, right? So the coronary sinus is entering or emptying the blood into the right atrium, and the deep system, as I have said, at any point they are emptying either into the right atrium, right ventricle, left atria, or left ventricle, right? So these they empty, and here we need to mention that physiological shunting. So it doesn't matter if these are emptying into the right heart, because that goes automatically to the lungs and it is oxygenated. But however, the vessels deep system, they are emptying into the chambers, those which are emptying into the left heart, that is the left atria and left ventricle. Now they are carrying deoxygenated blood and emptying that, or they are giving a venous admixture into the arterial blood, that is oxygenated blood, right? So that decreases the partial pressure of oxygen that is going into the systemic circulation or the aorta, is it not? So this we call physiological shunting, right? So that is one important aspect regarding, or physiologically we need to mention about the physiological shunting, the deep system that is emptying directly into the left heart, right? So with that, we now summarize. So the coronary arteries, they are branching, and these arteries, they are forming a subendocardial plexus under the after branching and entering into the endocardium. So they penetrate and they form a perpendicular system. They empty into the veins, but these veins again, they are not going into the superior or inferior vena cava. They are draining into the coronary sinus and through that into the heart chambers. So that is one more peculiarity anatomically or physiologically, right? And the deeper system, unlike emptying into the right heart, they are emptying into the chambers directly. Thereby, once they enter into right heart, it is okay. Otherwise, once they are emptying into the left side of the heart, they are causing the physiological shunting, right? Now, so now, before we go to the other peculiarities, I would like to just add a little about the methods of estimation of the coronary blood flow. So, there are various methods, the direct methods and indirect methods. So, directly, it is the electromagnetic flow meter, and we can also say angiographic methods that we are using. They are also what we do, the coronary angiogram and all. They are also the methods where we are injecting radionuclide isotope and we are taking serial pictures. So let us see a few methods and then we'll go to the peculiarities. So the first method, what we have said, using the fixed principle, what we say, the amount that enters is equal to the amount that leaves the vessel. And basically, when we are using the substances which are not utilized by that organ, right? So various organ systems, we just measure the blood flow by using this clearance or fixed principle basically. So here we are using the Ketty's nitric oxide method, where the nitric oxide inert gas, it is made to be inhaled, and we take the arterial and venous samples serially and we measure the amount of the gas, and we see the arteriovenous difference of the gas, and then we calculate the coronary blood flow is equal to the amount of the gas taken per minute or flow it indicates, and arteriovenous difference of that gas, right? Coming to the other methods, the radionuclide methods, here we are using either a thallium or xenon washout technique or technetium. So these three are the things, but the difference is few we are using which these few of these, they are localized much in the infarcted or ischemic area. Few go into area where there is high supply, right? So especially these two, if you take the thallium, is concentrated much in the ischemic areas or zones where the muscle is infarcted or dead, right? And this technetium also, it can be used to mark the infarcted areas. And now comes what we are routinely doing, as it has become a routine investigation for those patients complaining of the cardiac symptoms. So the coronary angiography. So this is nothing but we inject the opaque dye into the system, and we after the circulation time, once it reaches the coronary or a heart, now we take a serial photographs and we try to see the thing. So I think there's a pic here. Okay, I'll be showing later. There's an angiogram what I have kept, right? So that is the coronary angiogram, and it can be combined with the xenon washout, and we can measure the cardiac output. So coming to our physiological aspects, what we want to stress, the peculiarities of coronary circulation. So anatomic, what we have said, unique origin, they are direct branches of the aorta. From the base of the aorta they come, and they run from they run on the surface, and from epicardial to endocardial they have they penetrate in a perpendicular fashion, and they are basically end arteries. But however, if there is a chronic decrease in the blood flow, they develop collaterals, that too small branches, they develop collateral circulation. And obviously, because the area innervated, area that is supplied by these vessels is totally no overlap is there. They either they become the dominant vessels either right dominant, left dominant, or codominant, right? Coming to the physiological peculiarities, we have to say the phasic blood flow as the first important thing. So, what is phasic blood flow? Means the blood flow to the heart or the muscle of the heart or various parts of the heart. It is not uniform throughout the cardiac cycle. So, either it is less in the systole and more in the diastole. But however, this also is not uniform. So it is different from atria and different for ventricles. So the atria are not much, they are not showing that much variation when compared to the ventricular phasic blood flow. Means the blood flow is not same during systole and diastole, right? And how that is compensated, though it is there, or whenever there is an exertion or any other activity also, in spite of all these things, though not as much as the cerebral blood flow, here also the coronary also does show some autoregulation, but not within that wide range of mean arterial pressure, right? So it has its own autoregulatory mechanisms, and there is a regional variation of the blood flow. There is regional variation, and there is a variation in the rate of flow of the blood also to various areas of the heart. And there is a shunting, obviously. And the oxygen extraction ratio, again, when we speak of each point, I'll be elaborating a little more. So the oxygen extraction ratio, when we talk about, it is very high at resting stage itself in the cardiac muscle, and there is a high capillary density, and as a result of that there is a minimum diffusion distance. So let us see one by one. So to start with the phasic blood flow. So what is that phasic blood flow? As I have said earlier, so if you see here on the x-axis, we have the time, and here you can see this is the systole. So in the cardiac cycle, when we plot, right? So this is the systole of that, and this is the diastole. So this is the graph showing on x-axis the time, and on the y-axis the coronary blood flow in the capillaries of the ventricle especially, right? So left ventricle especially, if you take. So if you see the coronary blood flow, it is decreasing, and it is very low in the systole, and it is maximum in the diastole, right? So the rate of blood flow, we are saying, right, 250 ml or so is the resting myocardial blood flow, right? So that is there maximum during the diastole of the heart, and it is less, or it is falling down to the low levels in the systole, right? So the same thing we are seeing in the right coronary artery and left coronary artery. So these are the graphical representations of blood flow in the right coronary artery and left coronary artery. So if you see here, it is not much different in the right coronary artery. So though there is a variation, but it is having less in comparison to the left side, or in the left coronary artery, where you can see the blood flow is much less in the systole when compared to the diastole in the left coronary artery. So why this difference is there? So this is what in the capillary, this is in the right coronary artery and the left coronary artery. So this difference at the outset is because of the perfusion pressure. So the pressure gradient, always we say a pressure gradient is necessary for the blood flow. So let us also see what is this perfusion pressure, right? So before that, the other things what we have mentioned, autoregulation. So the autoregulation, the mechanisms or theories what we describe, myogenic theory and metabolic theory, right? So the autoregulatory mechanisms, when we talk, the both of them, and more of metabolic theory is accepted here, where the substances that are released as a metabolic end or end products of metabolism, they are responsible for the vasodilatation. So this is what we say, the vasodilator theory, right? So the other substances what we are saying, the adenosine, CO2, adenosine phosphate components, ADP and all, histamine, potassium, lactate especially, right? And H plus ion. So these are all the substances which are the end products of metabolism, especially in the cardiac muscle, adenosine, right? So the metabolism, right? Here, fatty acids are main substrate, hmm, nutrient here for the cardiac muscle. Next comes your glucose, and also here the end products, lactate, right? So those are all the metabolic end products. So here the in the vast here you see, if you see in this graph, on the x-axis you have the rate of metabolism, on the y-axis you have the blood flow. So this is the normal resting state, and as the metabolism increases, right, on the x-axis you see the rate of metabolism here. So as it increases, the blood flow also increases. So that is the metabolic theory. So that is the vasodilator theory. And the second one is oxygen lack theory, or nutrient or energy lack theory. So as the oxygen consumption is over, means whatever is available, it is utilized. So as the oxygen saturation comes down, so you see on the x-axis you have the arterial oxygen saturation that is being plotted. On the y-axis you see there is a blood flow, rate of blood flow. So here, if you see, as the oxygen saturation comes down, the blood flow also increases. So this is an indirect phenomena that is helping, especially the the coronary blood flow to be increased to the site of ischemia or need of oxygen when it is there, right? So let us see that auto-regulation here. So whenever there is a decrease in the partial pressure of oxygen, there is a hypoxia. So the when oxygen is utilized means when the activity of the heart is increased, right? So as the activity is increased means whenever the ventricular contraction increases, so when the heart rate increases, the contraction increases, sympathetic stimulation or exercise or any such conditions, the activity is increased, so it leads to hypoxia or decrease in the oxygen partial pressure or saturation, so leading to hypoxia. So that hypoxia, that causes increase in the adenosine pooling, is it not? So once ATP is utilized, adenosine is formed, and that is recycled to form ATP. But when oxygen is not there, that adenosine recycling back into ATP is not there, so this adenosine is pulled up. So this adenosine, once it is pulled up, here the typical aspect of this adenosine, it crosses the cell membrane, enters into the extracellular fluid, and that causes coronary vasodilatation. So once coronary vasodilatation occurs, there is restoration of the coronary blood flow, and there is again decrease in the adenosine, bringing back the situation or decreasing again the blood flow. So this is a very good phenomena that is seen. But however, if you see, this usually up to 3 hours that may be there, but later the other mechanisms also take up, right? So that is the thing. So coming to the other things, or other physiological significant peculiarities, there is a regional variation of the blood flow. So where we can see this regional variation? So basically, if you see the epicardial or endocardial areas, so the epicardial areas have much higher when compared to endocardial. So the compromisation of the blood flow is more in the endocardial or myocardial area when compared to the epicardial regions. And the capillary distribution also, the capillary ratio is high. That's what we say, high capillary density. That is also more in the endocardial area when compared to the epicardial area, right? So this is a compensatory mechanism that is helping in the to overcome the flaws that are there in the circulatory conditions, right? So the shunting, already what we have said, and we talk now about the high oxygen extraction. So the oxygen extraction ratio. So what is the oxygen extraction? So when the blood passes from the arterial to the venous side, in the capillaries there is some exchange, right? So the oxygen diffuses and it enters into the extracellular fluid. So that various factors, the partial pressure variation, the diffusion distance, all this will be having its own role. But however, if you see the arterial side, if it is 20 and venous side 15, means there is a 5 ml of oxygen consumption or extraction at the tissue level. So means the arteriovenous difference is indicating the oxygen extraction. So normally in the tissues, that is what we say, approximately 5 ml is the oxygen that is utilized. But unlike other organs or tissues, the cardiac muscle or the myocardium or endocardium, it has high oxygen extraction ratio. So this oxygen extraction, it is very high in these, and that oxygen extraction, it is almost, we can say, 75% of the oxygen is extracted, and thereby in conditions of increased demand, even though the blood is retained there for a longer duration, the oxygen saturation is such low that extraction is not possible from that blood. So the only way that can compensate this is to increase the blood flow. Means when the oxygen demand increases during conditions of exertion, the only way to give the oxygen supply is to increase the blood flow, because no more extraction can be done from the, so already much extraction, almost 75% of that is extracted, oxygen is extracted from the blood, right? So that is one important thing to be remembered. So the only mechanism by which we can restore the oxygen delivery is by increasing the blood flow, right? And the other thing, high capillary density and minimum diffusion distance. So let us see. So if you see in this picture, you are able to see these bigger ones. These are nothing but the muscle fibers. This is the skeletal muscle, cross section of the skeletal muscle fiber, showing arrangement of the skeletal muscle fiber and capillaries. So these small things are the capillaries, right? So these are the muscle fibers themselves. So if you are seeing here, the arrangement of the capillaries and the ratio of the capillaries is much more here. If you see, many capillaries are there, and the size of the cell muscle fiber is also less in the cardiac muscle. So more number of capillaries are there, the ratio is increased, right? More capillaries per muscle fiber in comparison when compared to the skeletal muscle. And as you are seeing, the distance between, because the size of the muscle fiber here is larger, the distance between two vessels, the capillaries, if you see, is much more when compared to that of, this is the cardiac muscle, right? So the distance between two capillaries is less here when compared to that of the skeletal muscle. So the diffusion distance means the territory in which the capillary is supplying the blood or oxygen is less here when compared to the skeletal muscle. So that is both because of increase in the capillary density as well as decrease in the diffusion distance between two capillaries, right? So the diameter of the muscle is also less here. That's what I write. So how that is compensated? So we said all the negative things about that coronary blood flow. There is a phasic blood flow. There are perpendicular vessels which are penetrating. So what happens if these perpendicular vessels are penetrating? What happens? The blood flow from myocardium, epicardium to endocardium. So as it is flowing, right, it's flowing. The one situation, whenever the muscles contract, they are constricting the vessels that are penetrating through them. Thereby, the blood flow in the endocardial area is decreased. So that's why during the systole, the blood flow to the endocardium is almost zero. Okay, so because these muscles, when they contract, especially the ventricle, left ventricle, it's contracting with much force, so much will be the compression. So that's why when we have shown the blood flow here through the right and left coronary artery, the perfusion pressure, again when we talk about, we'll be talking about that. So the compromisation, so in the capillaries here we have shown, right, the capillaries of the left ventricle are much compromised of the blood flow during systole when compared to the diastole. Is it not? So the penetrating vessels, they are passing in a perpendicular fashion. So when the muscles are contracting during the systole, these vessels are constricted or compressed. There, there is a pressure occluding the blood flow, thereby compromising the blood flow during systole, right? So the metabolic factors which are helping is basically it can shift from aerobic and aerobic, and the free fatty acids are the primary source of energy, and the next becomes your glucose and lactate, right? So the lactate, as I have said, the in ischemic conditions, when the metabolic end product is lactate, it will be pulled up, and that sensitizes, and that is responsible for the ischemic pain or cardiac pain, right? So what are the factors that are affecting the coronary blood flow? So as we have been speaking about, there are direct branches of ascending aorta originating at the base of the aorta, right? So that is the one which is dictating the perfusion pressure or flow of blood into the coronary vessels, right? So the other factors that affect are the heart rate, then the innervation of the coronary vessels, and the metabolic usage. So whatever, depending upon the demand, mm, how much oxygen is used and how it affects hypoxia, right? And local metabolites. So let us again revise one by one. So what I have been saying, the perfusion pressure. So as I have said, the aorta, it is uh, at the base, giving the right and left coronary arteries, is it not? So if you see the aorta, the pressure on the aorta, it is 120 mm of Hg during systole and 80 mm during diastole, right? So that is the systolic and diastolic pressures. So the in the left ventricle, a little more will be the pressure because it is pumping blood into the aorta with the pressure little higher than the aorta, is it not? So that becomes the pressure. So the gradient here is only 1, or in the aorta it is 120, in the left ventricle it is 121 almost. So the difference here is -1, is it not? So the blood is going from the aorta into the coronary vessels. So whatever gradient is there is very less or even negative. So that is responsible for decrease in the blood flow. That is also another factor which also is causing the decrease in the blood flow during systole. That is compromising. And during diastole, if you see in the left ventricle, the pressure is 0. It is in the relaxed state, right? So in the aorta, it is 80 mm of Hg. So the difference here is 80 mm of Hg. So that is allowing the blood to flow through the coronary vessels, right? So this scenario is different a little in the right heart or right ventricle, because in the right ventricle the pressures are relatively low when compared to the left ventricle, is it not? So here in the right ventricle, it is in the during systole it is 95 mm of Hg, so it is a low pressure system, right? So thereby there is a difference, so that is not much compromised. That's why in the diagram we are seeing in the left ventricle it is much more compromised when compared to the right coronary artery, is it not? Because of the difference of the perfusion pressures, right? So now coming to the application of that. So as we are saying, this blood flow through these arteries is also dependent upon the perfusion pressure. Two clinical scenarios we have to talk about. One is aortic stenosis. So in this aortic stenosis, the aortal, the valve, semilunar valve, it is in a steno state, means to pump the blood through that, the left ventricle is exerting much more. So higher pressure is there, means there is a almost 121 what we have said, so it further increases. So as it increases, the perfusion pressure further becomes much negative. So the coronary vessels are much more compressed, means the blood flow is much more compromised, and that also may be the reason of frequent pain, ischemic pain in the persons having aortic stenosis. So one more condition, again your aortic regurgitation, when we mention there, the pressure, though the left ventricle is pumping, the blood is not entering much into the aorta. So again, the aortic pressure decreases. So the blood flow is again compromised due to that in the coronary arteries. So and in the diastolic pressure, as we have said, the aorta, it is still becoming low. So further, coronary blood flow is compromised or decreased. So if you see the coronary blood flow relation to the oxygen consumption, so the same scenario what we are saying, as the oxygen consumption increases, the blood flow increases. So one reason what already we have mentioned is our hypoxia, that is your nutrient lack theory, right? So that is the cause. And coming to the scenario when the heart rate is increasing, so as the heart rate increases, the period of diastole is decreasing, is it not? So as the diastole is decreasing, there is the filling of the blood is less. So output is initially increased because of increased contraction of the ventricle. So increased heart rate conditions, usually the sympathetic stimulation will be there, right? So as the sympathetic stimulation is there, there is increased activity of the cardiac muscle. So though the diastole is shorter, the coronary blood flow is decreased, but however the metabolic component is also increasing. So that is compensating to some extent the coronary blood flow. So basically when the heart rate decreases, there is a period of diastole which is decreasing, so blood flow filling is decreased, blood flow is decreased. But however, compensation is due to the second indirect component, that is your metabolic component, right? So, as we have said, what are the neural factors that are affecting the coronary blood flow? Neural means the innervation. So, as we know, the heart vessels, they are having sympathetic and little parasympathetic innervation. So, the sympathetic innervation, though we say it is basically alpha and beta receptors, right? Depending upon the alpha stimulated or beta stimulated, there is either vasoconstriction or vasodilatation. But however, the alpha adrenergic receptors are less and not much significant, so beta predominant. So whenever there is a sympathetic stimulation systemically, when we say there is a vasoconstriction, but however, because of the beta receptors being beta adrenergic receptors being predominant, here vasodilatation is seen. That is the direct effect. And indirectly also, because of sympathetic stimulation, we'll see further how it causes vasodilatation. So ultimate scenario what we are seeing due to the sympathetic stimulation is a vasodilatation, in contrast to vasoconstriction in the systemic circulation. So here vasoconstriction and dilatation both occur, but which predominates is the end result what we see. So if you see here, in this, whenever sympathetic stimulation occurs, the beta receptors are there, we have said. So alpha are there, but they are not much significant, or they are less in number. So on the coronary arteries, you will be seeing beta receptors. So on the beta receptors, when norepinephrine and epinephrine they are acting, they will be causing coronary vasodilatation. So this is the direct effect, one mechanism, right? Another mechanism is the sympathetic stimulation, that innervates the wall of the heart, we say. So it is innervating even the ventricles, right? Entire heart it is innervating. So also the blood vessels, right? So as it is innervating, whenever heart rate increases and force of contraction increases, there is an increase in the myocardial metabolism, increase in the metabolic end products. So that is there is a hypoxia, increase in the CO2 or hypercapnia, H plus ions increase, potassium ions increase. and adenosine increases. So all these factors, they are responsible again indirectly for the coronary vasodilatation. So as a result of sympathetic stimulation, in contrast to the other situations, in the coronary vessels, we have vasodilatation, right? So in fact, this is very protective, because when exercise or any other situations or increased sympathetic stimulation, fight or flight mode, the heart has to pump more and give more supply to the skeletal muscle. So the heart, for it pumping more, it needs more blood supply. So that is aided by this direct and indirect phenomena of coronary vasodilatation, right? So this is what we have said, the indirect effect, right? The vasodilator metabolites, they cause the vasodilatation. So this again, when we are applying, so the inotropic and conotropic, that's what we have said, right? This discharge is causing the increased myocardial contraction and all. So in conditions where in like cardiac failure and all, so this, if we are giving the receptor blocking drugs or noradrenaline, or these are uh, given in unanesthetized hmm, uh, animal, it also causes vasoconstriction, is it not? So basically, in conditions, the drugs when you are using for other conditions, they may also affect the coronary circulation, right? So that is the thing. So what is the thing? Ultimately, it is happening whenever uh, there is a discharge. So ultimately, the coronary circulation is preserved, right? Either due to the direct effect of being the beta receptors, or indirect effect secondary to the metabolic changes. There is a increase in the circulation in the coronary vessels, right? So what are the mechanisms that occur during the fall in the blood pressure? So whenever blood pressure falls in the systemic circulation, there is a baroreceptor reflex. So as a result of the baroreceptor reflex, there is a vasoconstriction in the systemic vessels. And in the heart, when you see, you have the increase in the heart rate and force of contraction, leading to the metabolic concept here again, increase in the oxygen consumption, accumulation of metabolic end products. So all these things added along with the what we have said, predominant beta receptors being there on the cardiac vessels. So all these together, they are leading to the dilatation of coronary arteries. So basically, these vessels, they are not compromised of the blood flow in conditions where there is an increase or fall in the when there is a fall in the arterial blood pressure. So the baroreceptor reflex, basically whenever there is a fall in the blood pressure between 160 to 60, this will be activated, and that is preventing the compensation of the coronary blood flow direct and indirectly through the sympathetic activity, right? So also, as we have mentioned, the various end products of the metabolism, right? So coming to the applied aspects, we have to definitely, the very purpose of knowing about the coronary circulation is to know about the clinical aspects of ischemic heart disease, or angina pectoris and myocardial infarction. So what is this angina pectoris? What is myocardial infarction? So let us see. Basically, these are the conditions where the blood flow to the cardiac muscle is compensated, right? So what are the things? So if you see the blood vessels, the coronary vessels, if you are seeing, they are patent, allowing the blood flow, right? And whenever there is a plaque formation, so deposition of the fat material that we call plaque, upon which this becomes the one which is obstructing the blood flow. So there is a wear and tear, gradually the platelet plug formation, again fibrinolysis, again it will be, so gradually the size of this plaque will be going on increasing. So that is a chronic phenomena or scenario where the plaque formation occurs, and that will be compromising the blood flow to the distal part, right? So then there is a narrowing of the blood vessel, right? So this is the picture when you have a chronic ischemic heart disease. So there is, and as we talk about the same, the atherosclerosis, right? In that condition also, there is a narrowing of the sympathetic vasodilatation. It's not much effective due to the atherosclerosis. So that also compensates, or that also uh, should be overcome whenever there is a situation of decrease in the blood flow or increased demand is there, right? So let us see. So as we have said, there is a reduction of the blood flow, right? So as a result, the blood flow or supply is blocked, and if this plaque, what we call the one which is formed is a thrombus. So once it is gradually increasing in size and is obstructing due to the coagulation process that is going on, gradually deposition of the fibrin material and all, we say the vessel is narrowed or blocked. Is it not? The blood flow to that area which is supplied is compromised. And what is the time duration? So if it is basically over a long duration of time, chronic decrease, we have said to little extent, it is the protective mechanism, that is your collaterals, that is the small branches, they develop collaterals and they will be helping to overcome this ischemia, right? And this ischemia is will be more evident during strenuous exercise, right? So the stable and unstable angina, what we say, the person feels of the pain, anginal pain we say, right? So accumulation of the metabolic end products, especially lactate, those the substance P, all these things, the pain sensitive fibers, they will be uh, uh, sensing the pain, that is cause for the ischemic pain, right? So that is the area of infarct. So as a result of which we are seeing there is a chest pain, is it not? That is called the ischemic pain, right? So angina pectoris we define as the chest pain due to the ischemia of the, or ischemia means there is a lack of proper blood supply or oxygen delivery to the cardiac muscle, right? So where is it felt? Basically it is felt in the left, means usually we say that is the area, right? Over the precordial area, the we feel the gripping type of pain below the sternum on the left side, and this usually is radiating pain. So the person complains of radiation to the left arm, left shoulder, or the ulnar border of the hand, or sometimes to the neck and the jaw area, left side, right? And so basically that is the typical cardiac pain, right? So the angina pectoris we say. So if it manifests after exercise in strenuous conditions and later the person doesn't have that pain, right? So depending on that, or if it is over a long period of time, continuously coming, so stable or unstable angina will be saying, right? So if there is a ischemia, so we said there is a plaque formation and thrombus formation, and if this thrombus obstructs, we say there is a myocardial infarction. So the ischemia over a prolonged time, there is a death of the cardiac muscle, we say infarction, right? So the myocardial ischemia followed by infarction. So when this infarction is acute, we said there is a thrombus that is formed, and this thrombus, if it dislodges and forms an emboli, suddenly blocking a vessel, and that means once it enters into the smaller branches and it blocks there, the part which is distal to that, or that is inner way, that is getting the blood supply by that uh, obstructed vessel, that is lacking the blood flow. So initially ischemia followed by infarction. So if it is an emboli or sudden, we call acute MI or acute myocardial infarction. And typically, as we have said, the pain is there radiating, and also usually associated with excessive sweating. So when usually these things occur? So in conditions of stress and strain, right? So whenever the person exercises or suddenly he will be excited, so the sympathetic stimulation, as we have said, to be, if it is helping in compensation, that's okay. Otherwise, that is causing a sudden vasoconstriction and systemic, along with that blood pressure falls, and here that is not able to cope up and may lead to the acute mi, right? So what are the risk factors? As we have said, the risk factors, they are age. So the age, males especially, when we say, they are more prone for the ischemic heart disease because of uh, males, they are more prone, and compared to that, females in the premenopausal time, the estrogen, the protective effect of the estrogen on the lipid parameters, that is protecting the females when compared to males in the below 40 years. So above 40 or 45 years, the males and females are equally predisposing to the ischemic heart disease. So is one factor. Then gender, as I have said, the females have protective premenopausally when compared to males. Then the family history. So history of cardiac illness in the in the family, so they are prone to the thing. Then the cigarette smoking, so more than alcohol, cigarette smoking has much deterioration, that deleterious effects, because of it promotes the atherosclerotic changes faster, right? Then increased lipids, right? The plaque formation and all, the predisposition is due to the lipid deposition, right? Then hyperhomocystinemia, so the homocysteine levels is also estimated, because that is also one indicator of the person's risk towards the ischemic heart disease, right? Then hypertension, diabetes mellitus, so uncontrolled hypertension or diabetes mellitus over a long duration of time may be one risk factor for ischemic heart disease. Moreover, these, if they are for a prolonged time, may also lead to autonomic insufficiency. So the person may not be having the sense of that pain. He may not be able to feel that pain due to the neuropathy also. So silent mi is one of the important thing, risk that to be considered in chronic diabetes mellitus, right? Then the hemostatic factors, where there is a increased platelet activation, say there is a valve replacement or some foreign prosthetists that are there. So they are all the ones which are uh, triggering the procoagulants, right? Procoagulant factors. So those which are responsible for platelet activation, then fibrogen activation to form fibrin and all, antiphospholipid antibodies if they are there. So all these become the procoagulant factors, or they are responsible for increasing tendency of thrombus formation, right? So other important factors in the modern society, physical inactivity. So earlier they used to say, our parents, we used to walk, not parents actually, maybe the grandparents, they used to say, we used to walk from our home to the school long 10 kilometers. We used to cycle or we used to walk and all, right? Nowadays we have a AC bus sitting here, getting down there, right? So that may not be the one factor, but to mention the physical inactivity, obesity. So the junk food or whatever we say, obesity, one of the causes. Then anxiety, stress, all these things, they predispose or they are risk factors for ischemic heart disease, right? So coming back again, so we said the symptoms being the pain, that is the cardiac pain, typical gripping type of pain which radiates and associated with sweating, usually after in sleep, especially when those who are having all these predisposing conditions and all, or they say they have a sudden they pass the motion, so autonomic stimulation or these factors, right? So the symptoms will be sweating, there will be passing stool and all, right? So the autonomic act response is also seen, right? So what are the investigations we go for? Typically, first and foremost comes your electrocardiogram or ECG, right? Or EKG, right? So that is one very important thing, followed by echocardiography. So in the echocardiography also, you can see there is a decrease in the movement of the wall, cardiac wall. So the left wall or right wall or whichever is involved, the movement is less, means the infected area or the ischemic area has less movement when compared to the remaining parts of the wall, right? So that we can easily see the ejection fraction, the activity of the heart in this echocardiography. Next comes the treadmill. So the biochemical aspects also we'll be talking of, but the other things, the treadmill test. uh, so these are the important treadmill test. Usually we advise to investigate the uh, tendency, means a person complains of angina uh, or unstable or stable angina. If we want to know, or the person we suspect, we'll be doing a treadmill test where we'll be giving a guarded and guided exercise. We'll be asking, and during that time we'll simultaneously record the the ECG changes. So the ECG will be doing, and during exertion what we can see the changes, there will be evidenced, right? And biochemical tests, the enzymes. So the enzymes usually they are intracellular, is it not? And if they are increasing in the levels, they escape into the circulation, right? The damaged myocardium, it will be releasing the enzymes, especially to mention at the outset, the creatinine kinase, mm, LDH, troponin, lipoproteins, ultra-sensitive C-reactive protein, so oxidized LDL, these are all there. But much important is your creatinine kinase, troponin I, and homocysteine. So especially these three to mention at the outset, that is your CK, creatinine kinase, then troponin I, and homocysteine. So these are very strongly indicating an acute MI, especially immediately after a myocardial infarction, acute or uh, means there is a just immediately after the person complains of the pain, these they will be raised. So, to differentiate whether it's a myocardial or it's a recent or it has been from past, we usually go for the levels of these enzymes. So, this is becoming one more evidence to say it's an MI, or usually the confused with a gastric pain, right? So, ECG is one important thing. Then comes your enzyme levels, followed by echocardiography. And above all, if you have any doubt or though the not symptoms with age, or you want to evaluate as a routine checkup, right? We go for a treadmill, or any suspect is there, we may also advise coronary angiography, right? So that is more confirmatory, right? So if you see in this diagram, here there is a, you can see this is the uh, coronary artery. So this is the left coronary artery and the right coronary artery, right? So this is the right conus or the rami artery, which is supplying to the right atrium, right? So this is the right marginal artery, and this is the one which is going to the ventricular wall, right? So this is, here you can see the left coronary artery, anterior interventricular, and this is the circumflex, right? So this is nothing but your coronary angiogram. So we are injecting a radio dye, which is entering into the circulatory system, and so also into the coronary blood vessels. We take a serial radiographs where you can see clearly the blood vessels. So if there is a obstruction or emboli or thrombus here, from here the circulation will be cut out and you won't be able to see this. So basic knowledge, anatomical aspects of that. So you can see here there is a small narrowing, right? So you see a narrowing of the vessel. If there is a narrowing, or if there is a complete obstruction, from here you don't see the vessel, it is cut off here, the blood supply, like that. So it is very important for a cardiologist while doing angiogram to have a knowledge about the uh, artery, that is your right and left, their area of supply, which is dominant. So all these factors, they have a good role in survival of the individual, right? So what are the changes in the ECG, not to forget? So there is a elevation of the ST segment. So this is the ST segment. So this is the QRS. So this is the P wave indicating the atrial component. So atria to ventricle. So the time duration you can know, right? Activity. So atrial depolarization. So this is the ventricular depolarization and the atrial repolarization. So followed by, this is the ventricular repolarization. So you can see in the areas of infarction, you can see an elevated ST segment. And in the areas opposite to the innervation, means opposite to that, you will be seeing a depression of the segment, right? So this is a typical ST elevation in acute MI. So let us see what happens. So the things what we need to stress upon or look for whenever you are seeing a ECG are elevation of the ST segments. If it is there, it is the area overlying the infarction. So depending upon the cardiac cycle, if you correlate ECG, is it not? In ECG and the leads of the ECG, what we place on each area, that will indicate us which area or which wall of the myocardium heart is involved. Is it not? So the area, so if you are seeing the lead 1, lead 2, lead 3 you have, right? So these leads are placed over the, they represent the areas of the, so anterior wall, inferior wall, lateral wall of the heart, ventricle, like that. So from the lead in which these changes are present, we can also assess which part is involved. So here I have few pictures of the ECG. So here it is indicating in this line the normal ECG tracing in the various leads. So lead 1, lead 2, 3, AVR, AVL, AVF, and this is V1 to V6, right? So this is first part, it is indicating the normal tracing in the various leads, the ECG, how we see, right? And immediately after the incident or acute MI, so in the golden hour, that is what we say, right? So if the person comes in the golden hour and it is detected, we can give thrombolytic therapy that will restore the, and it will prevent the death of or infarction of the muscle. So over a period of 72 hours or so, if it is attended, the muscle damage is prevented. Before that, I mean to say, right, within the golden hour, 6 hours or 1 to 6 hours, we say golden hour. Within that, if we detect and we do a thrombolytic therapy, it can be restored, right? After that, gradually the ischemic area becomes infarcted and cellular death occurs, right? So to prevent that, early attention and treatment is significant, right? So in the early pattern, if you see here in this lead 1, there is a ST segment elevation. The other lead AVL and these two up to so V3 to V6 also you are able to see the ST elevation in the, so these are the infarcted areas. And in the opposite areas, so AVF and lead 1 and 3, and also in these 3 leads 2, 3 and AVR, you can see a depression, right? So in the areas where there is infarction, there is an elevation, that is the 3, 4 you are able to see. In the other opposite, you will see a depression. That is the immediate pattern what you recognize in the ECG, right? So later these things will be reversed, and late pattern is typically they return, and sometimes the Q wave they will be retained. So you will be seeing they will be reversed, right? So this is what is significant here. You can see they are simply given. So how do we treat? What is the physiological basis of treatment of myocardial infarction? So as I have said, the blood vessels, they are undergoing vasoconstriction. So one is the metabolic end products, they are dilating. But before that, if we are giving vasodilators, So sarbitrate, typically we'll be hearing in all the senior citizens, we advise to keep a 5 mg nitroglycerin or sarbitrate 5 mg, which is dispersible sublingually. If you place the nitroglycerin which is released, it is a vasodilator, right? So as it causes arterial dilatation, it will be decreasing both afterload, means the arterial resistance, peripheral resistance will be decreased. So in the systemic also it causes, right? So there is a decrease in the afterload, so the load on the heart will be decreased, and simultaneously it causes a venodilatation, right? So it decreases the preload also, and also in the coronary vessels it also causes some vasodilatation, thereby restoring the blood flow of the cardiac tissue itself also, right? So we'll also see how it acts. So basically it is a nitroglycerin which is helping in vasodilatation, thereby systemically also it decreases the workload on the heart, and as such per se in the cardiac muscle also it is causing increase in the blood flow by vasodilatation, right? So the second important, as I have said that the thrombolytic therapy, right? So streptokinase, then tissue plasminogen activator, these are all the things which will be used immediately, and they are the ones which help us to restore or prevent the damage further to the cardiac muscle, right? The other things are calcium channel blockers. So these also, they decrease the entry of the calcium into the smooth muscle, and thereby they cause relaxation of the smooth muscle, thereby causing vasodilatation, right? So calcium channel blockers, especially verapamil, that is also available, and the dispersible form can be used in a sublingual mode, right? So this is what I have said, the nitroglycerin or sarbitrate. So it will be causing smooth muscle relaxation, so vaso and venodilatation, and it will be also simultaneously causing coronary vasodilatation, decreasing the workload of the heart, thereby that compromised muscle is prevented from overexertion. At the same time, blood flow is also restored and ischemia is relieved. And remember, the atherosclerotic changes, if they are there, this is not much effective, right? So that is to be taken care. Then the antiplatelet therapy, so prevention. So in those conditions where the long hypertension, those which are who are on antihypertensive drugs, but they are also having risk, and the lipid profile is also high. So if you see the coexisting risk factors, we advise an antiplatelet or low dose aspirin or ecosprin 75 mg, that is the basic dose. So if you are giving, that acts as an antiplatelet drug, and thereby prevents the intravascular thrombus formation or the plaque being increased in the size, thereby it prevents the increase in the size of the plaque or deposition of the platelet over that, and thereby it exerts a protective phenomena, right? So the anti-platelet aggregating agents, that is your low dose aspirin or ecosprin 75 mg, right? So the other thing, as I have said, homocystinemia or increase in the homocysteine levels, that is also one of the factor which is causing damage, right? So the folic acid and vitamin B12, they will be facilitating or they'll be converting homocysteine to methionine, a non-toxic component, thereby they also help in preventing this acute MI or risk factor, right? So coming to the other modalities of treatment, coronary angioplasty. So as we have said, the angiogram, once it is done, we see a narrowing of the stenosed area of the uh, coronary vessel, right? We can insert a catheter and a balloon which is inflated at that site of uh, at that site of stenosis or narrowing, if you are inserting and you are expanding the balloon and retaining it there for a little while, that vessel comes back to the normal status. And if it does not, we can use a stent there, right? We can use a stent. So it is called balloon angiography, or here if you are using a stent, it is called coronary angioplasty, right? So we are dilating the constricted artery, and in that we are keeping a one structure, mesh like structure, which prevents the collapse again of that stenosed vessel, right? Then the last but not least, which makes the person young later again, right? So that is the surgical management, and this is preferred when more than two or triple vessel disease is there, major three or two or more three major vessels if they are involved, and it won't help with one or two grafts also, stents also. We may go for this, that is your bypass surgery or CABG, coronary artery bypass graft, where from a lower limb, other part especially, usually we go for the lower limb. We take a vessel from there and we graft it, bypassing the blocked area, right? So that will restore the blood flow, thereby help in regenerating the blood. So the collaterals also are developed, but however, this does not completely give. So if three or more major vessels, all the three vessels are involved, we usually go for a CABG, right? Thank you. Thank you. Sir, shall I just stop sharing my screen? Thank you for giving me this. I have taken the pictures, most of them from Guyton. Thank you. Uh, shall we? Shall I stop sharing the screen?
Thank you, madam. Thank you for your illuminating lecture.
Yes,
Yes,
sir.
ma'am.
Thank you. Thank you for giving me this
Now, I would
opportunity.
like to see any questions. Can you see, ma'am, if any questions
Pardon?
arise from the audience?
Pardon? Anything? Yes. Yes, sir.
Yeah, ma'am, thank you. Can you see any questions
No, sir. No question. Yeah.
Can you see if any appear in box or something? Yeah, illuminating lecture on the coronary artery circulation. So if there is no questions, or maybe audience may send their questions to you directly, or maybe to the PSI
Sure.
education
Sure.
committee, then these questions may arise to you. Uh, so
Sure.
maybe
I'd
thanks,
be
thank you, madam.
trying to.
Thank you for your lecture, Professor. We are grateful to
Maybe
Professor
I have
Kalyani
taken a little more
Mallipetti.
time, more than 1 hour, I think, 1.5 hour almost. I've taken a lot of time, I think, this topic. I've taken more than an hour, I think, more 1.5 hour I took your time. Thank you for giving me this opportunity. Right. Thank you.
Yes, thank you, ma'am. Thank you, Professor Kalyani Mallipetti, for your illuminating lecture. I would like to thank to Professor Prasun Priyonaik for his lecture session. The audiences who
Thank you.
Thank you, madam. Dr. Soma is having some uh, problem. Is again
Yes, sir.
connected? No, no issue. Thank you very much, madam. Thank you,
Thank you,
Soma,
sir,
for
for giving
your
this opportunity.
anchoring also. So we'll be going off with the
Mhm.
session. Thank you, everyone.
Thank you, sir.
Thank you. Thank you all.